The STAR-TREC trial is a phase 2, phase 3 randomized trial, in this case on patients with early intermediate rectal cancer. So they randomized the patients in three arms initially in phase 2 trials. So in patients receiving TME, which is the standard treatment for this kind of. No, we have to restart. Can you stop?
Yes, no problem. Whenever you're ready.
I didn't say anything about the category of patients. Okay.
Okay. Yeah, when you're ready. Thank you.
Okay. So the STAR-TREC trial is a phase 2, phase 3 trial in patients with early intermediate rectal cancer. Patients with early intermediate rectal cancer, in this case, were T1, from T1 to T3, A, B, that means tumor invading the mesorectum up to 5 millimeter, and 0. Also, in the STAR-TREC trial, the tumor volume should be less than 4 centimeter, and the tumor should not have high-risk features such as invasion of the mesorectal fascia or EMBI+. So the patients were randomized in a phase 2 trial to receive TME, which is the standard treatment for these patients, long-course chemoradiation in 25 fractions, and short-course radiotherapy followed by delayed surgery. The aim of the phase 2 trial was to see if there was the possibility to include these patients in such trial. The phase 3 of the trial was a randomized trial, randomizing patients who wanted to achieve a non-operative management, so an organ preservation between long-course chemoradiation followed by surgery and short-course radiotherapy. Before the randomization, all patients were asked if they wanted to be treated directly with TME. So the patients who wanted to be treated directly with TME were excluded by the randomization, but were included in the evaluation of their results. So the primary aim of the study was to evaluate the rate of organ preservation. And here the authors report the results at 1 year. So what they found at 1 year, comparing patients receiving long course versus patients receiving short course radiotherapy, they found that in the whole group, the rate of organ preservation was around 60%, and that in patients treated with chemoradiation, the rate of organ preservation was 80%, compared to 61% in patients who received short-course chemoradiation. So what they found, that long-course chemoradiation increases more the rate of organ preservation compared to short-course radiotherapy, in which the rate of organ preservation is 60%. What we can say is that these results are not mature enough. And in fact, we know from other previous trials already published that we have to wait at least 2 to 3 years to intercept the majority of tumor regrowth. And in fact, we have seen from the OPERA trial, for example, that 90% of local regrowth appear up to 3 years after the end of chemoradiation, and that the amount of organ preservation in this trial is around 25%. In the STAR-TREC trial, at 1 year, the rate of organ preservation is 18%. And even if these data are still not yet mature, we can see that the rate of 18% of local regrowth at 1 year is in line with the local regrowth at 1 year of the previous trial, which is more or less than 20%. So we can say that the data are not mature enough, but are in line with the literature. So the first question we have to answer is that if I want to treat that patient with an early intermediate rectal cancer to obtain an organ preservation, which is the schedule of radiotherapy should I use? Long course chemoradiation or short course radiotherapy followed by delayed surgery? The answer is long course chemoradiation, because long course chemoradiation has demonstrated an higher effect in decreasing the tumor. Then the authors went to see which was the effect of the initial tumor volume in tumor response. And what they have seen is that when the tumor is less than 3 centimeters, the effect of higher doses is significantly higher. And also this result is online with the literature and again with the OPERA trial, where it has been seen that increasing the dose has a significant effect on patients who have a tumor less than 3 centimeters compared to those patients who have tumor more than 3 centimeters, in which the increase of the dose does not increase the tumor response and does not decrease the local regrowth of the tumor. Looking at acute toxicity, comparing acute toxicity of the STAR-TREC trial, we can see that this is very low because the grade 3 acute toxicity of the STAR-TREC trial is 7%, compared with other trials such as the standard arm of the Rapido trial, in which we know that the acute grade 3 toxicity of chemoradiation is up to 25%. The reason under this decreased toxicity is in the volume that were used in this trial. And in fact, since this tumor are usually treated with total mesorectal excision, and total mesorectal excision for surgeons is the removal of the tumor, the rectum, and the entire mesorectum, the group of researchers decided to include in the radiotherapy volume only the tumor, the rectum, and the entire mesorectum, excluding the lateral nodes, and also decreasing the length of the mesorectum. This led to less toxicity of these patients. So I think that in the future, this trial could lead to a modification of the delineation guidelines. And the problem of the trial, but in general for the non-operative management, is that this patient must be followed very carefully. That means they have to go to an intensive follow-up. That means that the patients have to be seen by the doctor every 3 or 4 months for the first 2 years, and then every 6 months for the next 3 years, with an intensive follow-up, which means proctoscopy every 3 months, MR every 6 months. So we have to select the right patient who can be treated with this kind of treatment to obtain an organ preservation. So in conclusion for this trial, what we can say is that chemoradiation demonstrated better results in terms of non-operative management, so organ preservation for patients with early intermediate tumor, which means tumor less than 4 centimeters without positive nodes, that the results are not mature enough, but are in line with the literature, that the higher dose works better in those tumors less than 3 centimeters, and that we can start to consider smaller radiotherapy volume when we want to treat patients with smaller tumors.